Hello and welcome to yet another lecture number 26. In this and in a couple of other lectures following this lecture, we will specifically discuss about women's health issues, women health care, and the various institutions and arrangements made specifically with regard to women. And before we go into healthcare as such, I think all of us already know, but it's important to underline the special place of women in anything in society, because it is literally at the lap of women that a society is born. The child is born in the mother's womb and it grows up in the mother's lap. It's first, whatever it takes, intake, whether it's the milk or any kind of nutrition or any kinds of manners, any kinds of gestures, all of those things come from the mother's lap. So, as they say in Tamil, Thayai pola pillai, nulai pola selai, or the other way around, whichever way you take it, the quality of the sari is determined by the quality of the thread, and in the same way, the quality of a child is determined by the quality of the mother, and we can extend it to say the quality of a society is to a great extent determined by its women, especially its mothers. And while that matters generally, it matters even more particularly in the arena of health. The mother has to be healthy at every stage, when she is pregnant, when she is delivering birth to the baby, and immediately after the delivery. So, she should be in such a good state to bring kind of well-fed child, and well-fed children constitute a healthy society. So, generally speaking, of course, men's health is also important, but particularly women's health is of considerable importance to any society. And in a colonial scenario, there are particular difficulties, as we have been seeing. The colonial state is, from the beginning, had been very cautious about intruding too much into the indigenous social cultural systems. And of course, after a period of time, say from the 1830s, it felt confident enough to educate Indians or to reform Indians in the ways it thought best. But then after 1857, there were constant reminders of the uprising, and therefore constant concern about not overreaching. And so that applies here also. So, reaching out to women in the particular Indian social context was a challenging thing, because to reach out, and especially this is literally reaching out to the body of women. So, it's breaking the privacy of the women, but one's committed to public health, coming out of the earlier so-called enclavist frame. So, once the colonial state came into the public health mode, so there is no way it could talk about the public of that public health by ignoring about 50% of that public. And with regard to women, so that 50% we are talking about is about women. And with regard to women, there were particular concerns about their unsanitary conditions, for instance, with regard to the conditions after delivery, or with regard to say menstruation, other such things which are very particular to womanhood. So, there were more risks needing more attention. But then the question is reaching out to the women. So, which means already there is a problem with personnel, medical personnel. So, as we have been seeing, so they try to create as much of local personnel as possible, especially at the local at the lower levels of medical care. And so this issue of this very logistical issue of personnel becomes even more acute, even to reach out to women, even generally. And because there weren't too many women, so as it is, as I said, so there weren't too many Europeans in the medical services, especially at the top level, IMS and other such levels. And even at the lower levels, the Europeans did not normally bring their wives. So, higher officers, they came with the family, but otherwise, generally, there weren't too many women from among the European population here, so which at least could have paved some way of reaching out to the women, because it's all the more difficult for men and white men to reach out to the women population. And so even if there are white women, so since it's particularly about medical care, so there is also need for particularly trained personnel. So housewives can help. So whoever, whatever minimal number of white women were here, not professional, but housewives of officials. So that would have helped reach out to the women, at least to cross the cultural barriers. But in a more medical sense, in a more professional sense, it would be better to have particularly trained women health workers. So one fruitful way opened through the missionary route, especially women missionaries. Because and on the other side, the missionaries also saw medicine as one of the very fruitful ways of executing their original mission, which is spreading the religion, spreading the gospel. And also, as we have been saying repeatedly in the initial days, the colonial state was very concerned about not intruding too much into the social, cultural, and especially religious affairs of people. And for that reason, the company, in fact, banned missionaries because of the same concern about non-nutrition, and because they knew if missionaries were here, then they would act with a missionary zeal, not only spreading the religion, but also coming out against certain indigenous customs, like, say, for instance, sati and other such things as part of their missionary work, then which will have repercussions which they were very concerned about in the early days. But as I said, so as decades passed, there was a sense of confidence, and by around the 1810s, they decided, and this was effected in the Charter Act of India in 1813, allowed missionaries to enter India. And among their other activities, as I said, medicine offered a particularly bright opportunity to spread the gospel. So they began to involve themselves in the field of medicine. In the 1830s, one of the most famous missionary societies, the LMS, the London Missionary Society, began their medical work in southern part of India. And so they saw the potential of using women, so even local women, also eventually as nurses and doctors. And also the wives and daughters of missionaries could be used to reach out to the women folk first. As I said, it's also a challenge to reach out, whether medically or even otherwise generally. So the missionaries family, the women members of the missionaries family could be used to reach out socially, and then also through that for medical purpose. In fact, an exclusive women missionary movement was started for just for medical purpose. One such is the Zenana Bible and Medical Mission. So Zenana basically literally means something related to women, pertaining to women. And so in this case, it's also the part of the household in a Hindu or a Muslim traditional family, which is reserved for women. So here, so the challenge is to pierce that Zenana. So it's not only in the physical sense, but here in the figurative sense, it meant reaching out to the women part of the population by transcending that veil of gender, so going, and so which meant that you have to cross over the fence of the men folk, so in a larger literal figurative sense. So therefore, women missionaries were sent in 1840s, and later specifically professional lady doctors were sent to cater to the Zenana, the inner women's quarters. So this was projected as also in a larger cultural sense, because we have to keep in mind constantly that all of this had a lot of social, cultural, and other kinds of dimensions. So I keep repeating. So medicine was not just about medicine. So here, this particular missionary activity was also projected in a cultural sense as piercing the dark recesses of the Zenanas with the light of modern medicine, and through that, influence is gained over the women of the colonized population, and through that, so the entire household for religious purpose, and of course for medical purpose as well. So the Church of England Zenana Missionary Society and other such societies specifically recruited women to serve in India in the second half of the 19th century for this kind of work. So the task of such women were recruited was in fact to effect what was interestingly thought of as a double cure. So not only curing the body of a particular ailment or disease, but also curing them spiritually also from what was seen as a disease or whatever they are already following in terms of religious belief. So by the end of the 19th century, there were about 50 women missionary doctors from various denominations, various Christian missionary organizations, so representing 2/3 of all female physicians in India at that time. So this indicates the contribution of missionaries to the entire field of medicine. Of course, we will have a separate lecture on non-state initiatives where we will focusing on missionaries' diverse activities, including starting of colleges and other such things. So some of them opened hospitals exclusively for women and children. Of course, this was a considerable breakthrough. So as I said, this is like a big breakthrough that enables reaching to almost 50% of the population of that public, which should have been left out in whatever was the limited public health outreach. But the institution of parda, the seclusion of women, both so more than in a literal sense, but more in a figurative sense, the challenge of the men folk being too protective of their women and suspicious of any kind of exposure to the outside world. So all those kinds of challenges were there, and also even if some of these hospitals were for women and by and large staffed by women healthcare workers, there was a requirement that any such institution should be inspected by a male doctor. So that also kind of stood on the way, and so many Indian men were reluctant to allow their wives and daughters to visit hospitals. So going anywhere outside can be problematic. So we don't know what they are going to see, what they are going to hear, what they will learn, and what they will do when they come back home. So there was that fear that they will develop signs of independence and therefore begin to challenge the authority of the masculine authority in the household. So again, so see, you're talking about medicine, but this involves all these kinds of other social issues. So one of the most important landmarks with regard to healthcare for women in colonial India was the creation of something called the Dufferin Fund in 1885. So it was named after the Vicereine, the wife of Lord Dufferin, the Viceroy, so Lady Dufferin. So it was basically the starting of an association, which was the National Association for Supplying Medical Aid to the Women of India. So as you can see, the focus is particularly on women's health and personnel for women's health, and so which was done through raising of fund. So that's why it's called the Dufferin Fund. So, and its aim was to recruit qualified white women doctors, nurses, and midwives in Britain to be sent for the relevant medical work in India. And of course, eventually the idea was to train Indian women themselves to make healthcare available to Indian women in a more broader scale. So, what was the funding for the fund? So, initially, some of the funding came from the government, but as we have been noting, the government was always reluctant to spend and was, on the other hand, eager to encourage or to find ways in which the public can be brought on voluntary level the government always sought to bring up that culture of voluntarism as it was in Britain. So here too, the expectation was that there will be considerable donations and subscriptions, which did come from both Europeans and Indians, and it did prosper with several branches, both at home as well as in different Indian provinces. So, the fund widened the reach of Western medicine in India with a considerable leap in the overall number of patients attending hospitals and dispensaries, women patients. And of course, while doing any of these things, the colonial state could not totally change things lock, stock, and barrel. So, it had to continue with some of the social and cultural factors and limitations of, for instance, seclusion. So that cultural consideration for seclusion had to be maintained. So that so in these new institutions, the hospitals, women were not subject to too much of male gaze. So as I said, so the entire broader idea of Zenana was to keep the women in the house under the protective watch of their own menfolk. So, but here going out itself is one thing, and going to these kinds of particular places, it's important that there aren't too many men who see them or who come into contact with them. And the local press also was constantly demanding for such kind of arrangements, though the public opinion, at least elite progressive public opinion, welcome these kinds of institutions, these kinds of new attention to women and their health. They did insist on these kinds of cultural arrangements where the privacy of women is maintained. There's considerable room for seclusion. And so, as I said, there's a lot of local enthusiasm, and some provinces in particular worked very proactively with the Dufferin Fund. The United Provinces and Punjab province extended special grants for the improvement of the Dufferin hospitals, and they also bore some of the expenditures of some of the Dufferin Fund institutions, like whatever local dispensary or hospital. So, some of the expenses associated with that was also borne by the respective provincial government, and these provincial government also from their part provided female branch dispensaries within the within the existing hospitals, but these special dispensaries with female assistants, hospital assistants for women of all classes. And so these kinds of arrangements had impact even on the admission. So admissions means they've been getting admitted to the ward. So as we already saw, there were lots more women actually visiting, like what you call OP now, outpatients. So apart from the increase in the number of women visiting, so there was also increase in people being admitted. So there was increase in the average occupation of hospital beds by women in both these provinces. The Dufferin Fund also interestingly involved another important social and gender dimension. This is with regard to the British women themselves, because the whole thing was about healthcare for Indian women, supplying personnel for improvement of health facilities for Indian women. But this is also something about British women themselves, especially the special roles of wives of those in government service, starting from the Viceroy. As we saw, the fund itself was named after the wife, after the name of the wife, the Viceroy Dufferin. So, who in fact showed her role as an extension of her feminine identity as a wife. But of course, she also rose to be a public figure in her own right, beyond the shadows of her husband or the office of the Viceroy, due to her close association and very active work with the Dufferin Fund. Similarly, after that, the wives of succeeding viceroys, these subsequent vicereines, also involve themselves in this and other kind of charitable initiatives, especially those related to providing better facilities for women's health. And there was also a general expectation among the wives of the upper class English, and in this case, particularly the ICS officers and other higher level employees. So, their wives to be associated with some charitable cause or the other. So, that was seen as a kind of a social, more kind of social status also. And on the other hand, as far as the bodies are concerned, the particular agencies or organizations, so like in this case, Dufferin Fund. So, as far as they were concerned, so it was a great advantage to them because it gave privileged access to the royalty. So, for instance, say if it's the Viceroy, so in fact, in the case of the Dufferin Fund, the Queen Victoria herself also had a role. She in fact impressed on the Viceroy to proactively go ahead and start this because of some representation made to her. So, that kind of access to, if not always to the royalty, at least to the Viceroy here, and then to the all the officials who work under the Viceroy. So, this kind of an arrangement gave the Dufferin Fund quasi governmental slant. So, it was the nature of it was became more and more of a quasi governmental one. So, and they projected themselves as rescuers of confined traditional women by exposing to the, these are all the claims, by exposing Indian women to the light of modern scientific medical care. Officials, that is male officials, also served on the Dufferin Fund in honorary capacities, but again because they had those other official positions and links, there was that advantage to the concerned organization in practical terms. So, they may be honorary post holders, but because they had those other posts in the government service, so the benefits of those links are available for the particular agencies. So, as I said, voluntarism is something which the colonial state tried to bank on to a great extent, and because it was an important aspect of healthcare in Britain itself. And here in this case, the Dufferin Fund tried to foster that culture, especially in the light of the continued reluctance of the colonial state to fund extensive public health measures. And of course, when you are doing it for women's healthcare, so the benefactors, it was expected that the benefactors, the philanthropists will have a special sense of belonging, considering the special place, central place that women have in society, as I said earlier. So, the fund itself was modeled on the subscriber democracy model, as in the British voluntary hospital system, and which the British tried their best to replicate wherever possible in the Indian context. And the newspapers at that time, in fact, talk about the very generous contributions made by the public. For instance, in 1886, the Bombay Gazette expressed satisfaction at the contributions from wealthy representatives, so even among the Indians. The Hindu patriot lauded Lady Dufferin for opening up this avenue, so which gave the opportunity for Indians to show their munificence for this very important cause, both the social as well as the medical cause. And so naturally, because of this kind of, at least in the early stage, there was this kind of a generosity. So the DF was in a very quite, itself was quite healthy in its financial state. So for instance, in 1891, we had the statistics. It had 11 lakhs of rupees invested, which gave it an annual income of rupees 50,000. The private donations and subscriptions for 1891 for that particular year itself totaled about 1 lakh of rupees. And so with that, so they could think of employing appropriate trained medical personnel. For instance, 13 female practitioners with higher qualifications and the LMS degree were employed. Then there were 27 assistant surgeons with other levels of qualifications, certificates and diplomas, and 21 of them were Indians at that level. And it also sponsored people who are still getting trained as the students in the various colleges or institutions, so working for their various diplomas or certificates or degrees. So now about 400,000 women had received medical aid at DF's hospitals and dispensaries. So this is the people who are attending the patients. So by that time, around the 1890s, so this was a considerable thing. So just about 5-6 years. And by 1892, there were 10 provincial branches in India and 120 local and district associations overseeing as many as 48 hospitals, specially meant for women. And all of this was supervised at an overall level by committee, central committee operating from London. And as in anything in life, there is criticism, and there was criticism for the directed towards the Dufferin Fund also. So it was seen as a kind of an example of British paternalism. So with all the kind of language, the kind of projection of taking rescuing Indian women, taking them from darkness to light, or even more saving Indian women from their own men folk. So that kind of imperial gender ideologies were sought to be perpetrated. And another important thing is that criticism is that about the inadequate employment of Indians. Of course, Indians got cured, Indians had better facilities, both at the dispensaries as the ward and bed level and all that. But to what extent were Indians employed, especially at the higher levels? We saw just now there were Indians, but there was disappointment, particularly with employment of Indians at a higher supervisory level. This in spite of the fact that there were several Indian Christian women who had obtained medical degrees. And in spite of that, only 11 fully qualified doctors were employed by the association, that is 11 who were Indian. And the Central Committee of the Fund defended the exclusion of Indian women, so it was not apologetic. So it said so there are problems of age, there are problems of experience, and then we have our own reasons, which is understood. So we can't entrust such higher level jobs to Indian women. So they had their own justification for that. The number of Indian women opting for training as hospital assistants and apothecaries was very low, and of course this was related to financial reasons, because their pay was low, and they found themselves as too inadequate with proficiency in English. And also in due course, because as I said, the Dufferin Fund, apart from providing healthcare, also later on went into the realm of training people within India. So there was a criticism of that training, so it was deemed to be a very defective education. And in course of time, the financial health of the Dufferin Fund was not as good as it was in the beginning. So there was concern and criticism of worsening financial position, and also important question of privacy in the hospital, because as it is, there was that standing requirement that there should be at least one male doctor overseeing the functioning of any of these institutions. So that was there, and as we will see, there are other criticisms which are being expressed subsequently. So we will see them in another lecture. On that note, we will close this lecture. Thank you.